Dr. Oller is a primary care and addiction medicine physician and served as one of the first Rural Health Leadership Fellows and Chief Resident at Massachusetts General Hospital before coming to UK. He's Associate Program Director for the University of Kentucky Internal Medicine Residency Program and an investigator for the NIH-funded Healing Community Study. Dr. Liza Bastin is a resident physician in primary care program, in addiction medicine track at the University of Kentucky. She plans on practicing primary care in London, Kentucky upon graduation. Dr. Bastin has an adorable puppy named Paprika, and I very much appreciate you adding a picture this time around. So welcome back to Dr. Bastin and Dr. Oller.
Thanks, John. We don't have any financial disclosures. So our practice gap, so several behaviors, including gambling, internet gaming, binge eating, compulsive buying, significantly impact the well-being of individuals that we're working with. Unfortunately, research is lacking in how to best approach diagnosing and managing these behaviors. We know that these behavioral addictions overlap with and impact the treatment of people living with opioid use disorder and serious mental illness. Again, we hope to identify some key characteristics and what's happening in the brain that's shared by these problematic behaviors, or compare and contrast some of the diagnostic criteria and how we diagnose gambling disorder and substance use disorder, and hopefully spend some time going over pros and cons of management options available. And we hope that you guys take this information and it allows you to readily identify folks seeking or already engaged in opioid use disorder treatment, trying to make sure that you can pick up on when these behaviors are happening and get them the community resources and treatment options that they need. So last time, we're going to spend just a few minutes giving an overview of some of the key themes and issues we discussed last week. But just as a way of a review, we talked about how there's different frames that we can view a patient's struggles through, almost like the different panes of a window. And the four that we talked about were sort of the disease perspective, which is what a patient has, the dimensional perspective, which is who the patient is, the behavioral perspective, which is what the patient does, and the life story perspective, which is what the patient encounters and how they respond to those life events. And by looking at each one of these, we can glean sort of both what might be going on with the client, but also how we might be able to help them. We talked about how the behavioral perspective, when we're just focusing on that, what we're looking at is how choice, a decision that a patient or a client makes, is actually being driven by what they've learned, what they've encountered in the past, and how they've behaved in the past, which is based on prior experience, so rewards or consequences. And that creates a psychological drive. And as that behavior is repeated again and again, that psychological drive becomes almost a physiological drive, right? In the same way that hunger or thirstiness or the drive for sleep really can sort of hijack our brain and say, we're shutting down, right? And we're just going to focus on satisfying this drive. When that behavior is repeated, there are actual changes in the brain that occur that make it more and more difficult to break out of that cycle of the behavior. And we know this because we see how signaling changes in the brain, where early on in a behavior, like say gambling, we see a lot of activation in the psychological drive area, our reward pathways, which is in the nucleus accumbens in the ventral tegmental area. So we get the surge of dopamine when, say, we win a jackpot while we're gambling, right? But over time, those dopamine surges decrease, And we see more activation in the brain in sort of the autopilot center. And that's that's what sort of causes us to tie this, what was initially a psychological drive, to what now feels like for many folks who are in the middle of it, like just like hunger, just like the need for water, just like the need for sleep. They begin to see that behavior as this really essential part of getting through their day. So our questions, we got some great ones, and I'm be interested to see if there's other ones as we go through this. But our questions are going to focus on a couple of different things. And as we're going through this, there's a few exercises that we might do together. So if you don't already have, a piece of paper or a pen with you, try to grab one of that and one of those, and because we'll need it a little bit later on. Okay, so the first question that we got pertains to hoarding. So hoarding disorder is actually a new diagnosis in the DSM-5, sort of our textbook of psychological and psychiatric diagnoses. And it used to be categorized in the previous edition of the DSM-4, as sort of this sub behavior under obsessive compulsive disorder, or OCD. But as they learned more, and as they did sort of separate research on hoarding, they found actually it seems to be a distinct entity. It's its own thing. And the prevalence is, while still pretty low, affects a fair amount of people, so 2.5% among adults. It's really commonly associated with an independent mood disorder. So, and so the largest studies that I looked at, it was anywhere between 20 to 40% of people with a hoarding disorder also have major depression or generalized anxiety disorder. And I think just like with some of these other behavioral addictions, that becomes an avenue to pursue treatment, right? It may be that as we get some of those mood symptoms under control, we're less likely to reach for this behavior to satisfy an issue going on. And obsessive compulsive disorder, and this is why these are separate categories now. The hoarding behavior is often distressing to the individual. It's often the result of, if they feel like within the ritual of their OCD that something no longer can be sort of touched, then they don't get rid of it, because that would be that would get in the way of satisfying sort of the internal drives that come with OCD, but they don't like the disorder that comes with hoarding as well. In hoarding disorder, it's folks don't have as much of that psychological distress at seeing sort of all the items that they've accumulated. When we dig down to it, it has similar criteria to some of our other behavioral addictions. The main sort of characteristic is that folks have a persistent, difficult time with discarding or parting with possessions. And this is the key. It's regardless of the value of those possessions. So we talked about how in compulsive buying, it's less about actually obtaining the thing. It could be an eBay auction for a small trinket that's $5, and that doesn't matter to the individual. It's the actual behavior that is driving things here. And we see that that there is some overlap. I would say a pretty significant overlap of people with hoarding disorder who also engage in some component of it, excessive acquisition, right? So there is some overlap here with compulsive buying. a couple of key questions that you can ask, and often you have to be pretty direct in asking these questions, is do you find it difficult to discard or part with possessions? Or do you have a large number of possessions that clutter the main rooms in your home? And if folks are answering yes to one or both of these, then you may want to proceed with some more advanced questioning. So this is a hoarding rating scale. And of course, if you want to take a snapshot of this, or we can include a link in some of our future newsletters, but this is from basically a 0 to 8 scale, 5 different things from, because of the clutter of your or number of possessions, how difficult is it for you to use the rooms in your home, right? So this is getting at how it's not just sort of the behavior of collecting things that's a problem. Like we collect weird things all the time, but is it getting in the way of what a normal life should look like, right? So is it cluttering? Is it difficult to navigate your rooms? How hard is it to discard or give away ordinary things that other people would get rid of? So that's getting at sort of, do they acknowledge that even this thing doesn't have really a lot of intrinsic value, and is the act of hoarding something that they actually get that dopamine rush with? To what extent do you currently have a problem with collecting free things or buying more things than you need or can use or can afford? So this is also getting at sort of complications from the hoarding behavior, which are often financial, very similar to compulsive buying. Extent of emotional distress, right? Another complication. So, and then to what extent do you experience impairment in your life because of the clutter? So these can be useful questions. Of course, the higher scores that you have, the more severe the hoarding behavior is, and the more likely somebody has a true hoarding disorder. And like with some of our other behavioral addictions, really CBT is the main treatment for hoarding disorder. There's certainly affinity groups and mutual aid groups that are helpful as well in some small studies. And this sort of goes over the different, the sort of model of thinking and sort of both the fixed beliefs and maybe irrational beliefs that folks have who are engaging in hoarding behavior. And so just focusing on the beliefs about possessions box there, I think these are really important, right? So emotional attachment to possessions. So this sort of sense of hyper sentimentality. And that might be because that item is associated with a significant loss. So it might be, my mother collected these, and so that's why I'm not getting rid of them. But we've taken that to the extreme of buying additional items that mom collected. Responsibility for possessions, right? So that might be driven by prior traumatic life events where there might have been attachment issues or concerns. And so you feel sort of this out-large sense of responsibility for taking care of something that's within your control. And that sort of need for control over possessions, and then concerns about memory as well. So one thing that we want to do for all patients with hoarding disorder is making sure we're assessing their memory function, right? Is this actually not being driven by that behavior, but rather it's a coping mechanism for significant short-term memory loss in the case of a dementia picture. So this can be a pretty complicated diagnosis, but my takeaways are, there's a lot of overlap with compulsive buying disorder. 60% of folks with hoarding disorder are going to engage in some level of excessive buying. But it goes back to, the differences go back to where in this loop of the behavior, you're getting that dopamine rush, right? So in the compulsive buying, they have distress from not buying things, their mood worsens, and you get that rush and that relief when there is the purchase. Whereas that relief, that pleasure for folks with a hoarding disorder is more likely associated with sort of seeing their items, accounting for their items, checking in on or displaying their items in a way. So, and over time, you run into more and more issues and struggles resulting from that behavior. So any questions on hoarding?
Okay, I'm going to pick up with the next question. So someone asked, is opiate use disorder, substance use disorder, can they be both a substance addiction and a behavioral addiction? So I think this question is kind of asking for kind of like picking hairs between semantics, whereas a behavioral addiction by definition doesn't involve a substance, but we know that behavioral addictions act the same way as substance addictions in a way, because it's the activation of those same pathways. So I would say, like, more technically, it can behave the same way as a behavioral addiction by activating those same dopamine pathways, the reward pathways. You see the same cycles of the preoccupation, the tolerance, so the wanting more and the more, and having withdrawal when separated from the substance or the behavior, and then kind of going into the relapse and then the preoccupation and going back into that cycle. So kind of looking at those two different things, your substance use and your behavioral addictions. I was reading just more online about this, and I found this really interesting paper. It's a little older, it's 2012, but it was just comparing the behavioral addictions and substance addictions really side by side, with both like a psychiatric view and a psychological view as well. So if you want to go the next slide, I thought I included the link. If not, I can email that out. So this study kind of looked more at the internet gaming addictions that Dr. Oller talked about last week, and comparing those to different drug substance use addictions, and comparing the same feeling brought about from the action. So it was kind of stressing where with a substance use, you get a direct activation of those pathways. And then in the behavioral addictions, it's more of an indirect activation. So instead of physically putting a substance in our bodies, we're making these pathways happen ourselves by those behaviors, by releasing some of those endogenous opioid responses. So the chemicals in our brain that are activating on those opioid receptors, making us feel that sense of pleasure and that sense of reward, like the dopamine giving us that rush of pleasure as well. So I just thought it was a really nice article to read side by side about some of those different things and comparing them. Kind of how we talked about last week as well. And then it also kind of brought back how people can be a little bit more susceptible to both substance and behavioral addictions. Maybe they're depressed, or maybe have a genetic predisposition that makes them more susceptible to those pathways and that rush of pleasure, and making it feel more like the psychological drive, like Dr. Oller was mentioning a little bit. And they just might be more susceptible to that for whatever reason, whether that's genetic or influenced by substances or just learned behaviors throughout their lives. So there's definitely a lot of overlap with those two, but by definition, I don't think that we can call a substance use disorder technically a behavior use disorder, just for the fact that it has the use of a substance at the baseline. So I think those are my biggest points on that question, kind of the indirect versus the direct use of the substance and that overlap. And then going back to those pathways that Dr. Oller showed again with your upregulation over time with the addiction, and turning what is a natural pathway into more of a need. So any questions about those two comparisons or the definitions right now?
I would just add that, and we talked about this a little bit last week, I think how society views these has shaped the way that we think about them a lot as well, right? So if you think about a lot of the behavioral addictions, it is not against the law to hoard things. It is not against the law to gamble, even to some extent, right? But it is against the law to use heroin, right? And so the way that we sort of conceptualize of these as a society, the stigma that's associated with a substance use disorder is perhaps a little bit greater than some of these behavioral addictions. And that's not to say that that folks living with a behavioral addiction don't have it as bad as somebody with this. It's just different, right? And part of that difference is shaped by how we as a society view these different behaviors. And John makes the point in the chat that makes sense. I've heard that people quitting smoking sometimes have had to hold pens as they quit, or sometimes have an oral fixation with both sounded like behaviors, right? And we talk about sort of the injection behavior too. The quote unquote the sort of needle addiction, and that's very true. And so when you're talking with clients about injection behaviors, you can ask them sort of, when do you start to feel that sense of relief? And for many, it's before the drug is even acting. It's with sort of the poke. It's when they find the vein. It's as they're sort of pushing down the plunger. And that's before the brain is the drug is actually getting to the brain. They're getting that relief because there's that behavior. You think about sort of cutting in a similar way as well, right? And Barry makes the point that gambling is encouraged in Kentucky with the horse industry. Absolutely, right? I think there's a ton of overlap. There's a lot that substance use disorder researchers like myself can learn from folks living with a behavioral addiction. And there's a lot of things that folks with a behavioral addiction can learn from people with the lived experience of say, opioid addiction. Other thoughts or comments on differences or similarities that you guys see? So are there common behavioral addictions that persons in substance use disorder recovery develop? So this is a little bit of a complicated question, and it's in part complicated because of how research has generally been done in this field. So unfortunately, most studies look at the prevalence of substance use disorder within a population where we already know that they have a behavioral addiction, like say gambling disorder. So I see one of the best researched association is gambling and alcohol specifically. You see gambling plus another substance use disorder is still fairly prevalent, so about 1 in 5. But 2 in 5 individuals with gambling disorder also have an alcohol use disorder. And some of that is just on the supply side, right? So when you're being comped drinks and other things at a casino, you are going to be at that higher risk for developing an alcohol use disorder. We also know that those with behavioral addictions and a substance use disorder are at higher risk for a poor response to treating their substance use disorder. And that's, we see that in the same way as people with multiple substance use disorders, right? Because if you have one substance use disorder under control, let's say somebody's on methadone or on buprenorphine, their cravings, their urges are well controlled for opioids, but they're still struggling with a stimulant. You would want to try to isolate and evaluate as much as possible that stimulant use and understand what might be helpful there. But that can really get in the way of them showing up on time for appointments, making sure that money is going to savings and not towards stimulants, controlling their mood symptoms when they're riding the ups and downs of stimulants. It's the same thing with gambling or compulsive buying. Those individuals are riding the ups and downs, the emotional roller coaster of wins and losses that come along with gambling. We also know that very similarly to substance use disorder, there seems to be a fair amount of a genetic component to developing behavioral addictions. So between sort of 30 and 60% of at least gambling disorder has some sort of genetic component to it. And that is very similar to substance use disorder. And then lastly, sort of, and we were making this point on the previous question, there's this component of how much society is influencing this as well. What's normalized, what's okay, what's not okay. But there's also sort of shared pathways. As much as there's shared struggles, there's shared pathways for recovery. And I wanted to show you this video of a gentleman with a gambling disorder. And he sort of had his first experience going to a Gambling Anonymous meeting and shared sort of this video about what it was like. And I think you'll find a lot of similarities with what we hear from folks going to AA, SMART, or NA meetings. So let me stop here.
Every single type of person from every which way in life in general. One thing that I like to do is I like to just observe the room. I really listen intently and pay attention to the stories. And I pay attention to the people that's telling the story. So the people that are in there are young, old, married, unmarried, Asian, black, white, Italian, Hispanic. One thing that I do want to mention to you guys is that somebody recognized me and say, "Oh, hey, what's going on, Anton?" after we was leaving and everything. Whole nother story, whole nother conversation. But yeah, it was just like everybody from every walk of life. And it was only like 12 people there. But I'm telling you, man, if you did a focus group, everybody is just from a different background, a different age, a woman, man. It was like evenly split, the whole 9 yards. As it relates to the program itself, I don't know if it's different for different GA meetings like across the nation or whatever, but for this one, we spent the first half hour reading.
Here are the steps which are a program of recovery. 1, we admitted we were powerless over gambling, that our lives had become unmanageable.
Really capturing what it is to be a compulsive gambler.
5, admitted to ourselves and to another human being the exact nature of our wrongs.
What the history says, how we should operate and conduct ourselves, and really acknowledging our behavior as it relates to everything that's led up to this moment of us being in this meeting.
We're entirely ready to have these defects of character removed.
With it being my first time, I learned that you go through this 20 question list, and the 20 questions basically is like, it's a wide range of questions, and basically I learned that most people on average answer at least 7 of those questions as a yes. I guess it's like a 12-step program. I've heard of that with Alcoholics Anonymous, but it's like a 12-step program. We specifically focused the second quarter of the meeting, so like the second 15 minutes after reading, on tackling step 8, which was like making a list and trying to acknowledge and make amends to all the people, including yourself, that you've affected within this lifetime of gambling or compulsive gambling. Second half hour was really people talking about their date and, their week, how they're progressing, if they're having any like issues as it relates to dealing with other people. Some people was talking about how they were out at dinner and, they was like somebody had forgot their phone and they was like, "Oh, you can send a text through my phone." And then his wife started going through his phone, even though he hasn't done anything for like 6 years straight. His wife started going through his phone, and then she found like a text message where he was arguing with somebody else over money that they owed him. And then she's like, "Well, what the heck is this?" And it's like, but it was completely unrelated to gambling. But, the people, and this was like a few people's stories from their week, from all different walks of life. It was like you know, the people in their lives, they got to continuously try to make them feel comfortable with the person that they've become and not live in their past.
We'll stop there. Love to hear sort of reactions from folks just hearing about that, and sort of how it overlaps with or maybe contrasts with some experiences with other mutual aid groups.
Well, I hope this applies, but I mean, this happens a few times a month, and it happened this week. You know, my wife, she's not like me, and so you know, the first of the week, we say, okay, this is the cash you need for the week to get your fuel, to get food, and we have a gosh, I'm sorry, I'm just at a loss for words. We have a budget that we follow, and man, when the budget gets tight on my end, for instance, she gets antsy, she gets nervous, and has a lot of questions. And you know, I understand that completely. I don't blame her one bit. It makes me feel like I'm not trusted, of course, and I sometimes I take that personally, but I don't blame her either. She dealt with my addiction and my substance use disorder for years while I wasn't in recovery, and I can't blame her a bit. So it's tough. And it took me a long time. I've been in recovery since 2014, and it took me, you know, well, no, I'm still in the process of learning to accept her reaction to that. And but it gets better every day. So
yeah, thanks for sharing, Barry. And I think that was one of the points that really resonated with me as well, of trying to help our clients, trying to help our patients understand these reactions that they're getting from family members, friends, people that care and love about them, love them. Like that is a huge sort of mental strain, a stressor that a lot of folks living in recovery, not just from substance use disorder, but from one of these behavioral addictions, really are facing on a day-to-day, hour-to-hour basis. I'm wondering what other parallels or differences folks thought of as they were hearing this story.
As I was listening to the story, it kind of brought to my mind how a lot of my clients, when they are in the early stages of their substance use disorder, as far as the remission, how they often say that they feel scrutinized by family and loved ones. It's kind of like in the video, and then often it's kind of like a trigger for their continued use, because they're like, I'm trying, I'm still getting blamed for all this bad stuff. So kind of what's the point? Right.
And I think in parallel to that, we can see how folks who might be in recovery from their opioid use disorder, like they feel relief and reward from, say, gambling or compulsive buying or something like that, that feels less stigmatized, that feels like there's less judgment associated with it compared to their prior drug use. And Tasha makes the point in the chat, it's almost a conditioned response by loved ones to automatically look first at the wrongdoer or who the person is that has done the most harm, right? So again, I think a lot of the work that we face, both in for folks with opioid use disorder and those with behavioral addiction, is trying to think through what responses by the people around them are really causing the most distress, identify those, help them work through their own perspectives. Okay. Moving on, Liza's going to talk a little bit about social media as a potential behavioral addiction.
Yeah, I think this is a very hot topic now, actually, with social media becoming more and more prevalent in our society and constantly changing and evolving, really right now as we speak. So the question was, is there a DSM diagnosis for social media disorder? So I would say the answer is not yet, but it would not surprise me at all if that were to come about soon. And then I guess the other part, I've seen news stories about teens becoming addicted to social media, developing depression, anxiety because of social media. Is this related to behavioral addictions or something else? And I think the answer to this question is probably not clear yet. So there's a lot of studies right now trying to evaluate behaviors associated with social media and really get at more criteria and more of like screening questions, ways to be able to, describe, okay, when does social media use go from, just a use to being maybe problematic to maybe going over to, okay, this is now a disorder, this is a classifiable addiction. So I think one of the barriers to both this question and then is it in the DSM is that we don't have a really good way of classifying that yet. So if you go to the next slide, please. There's a lot of studies out there right now trying to classify this and trying to find methods as to how to identify this realm of potential addictive behavior or pathological, like when is it a problem that could be called a disorder. And I apologize, it's kind of blurry here. But this is a paper that was from 2016 and it's called the Social Media Disorder Scale. It's gotten some attention online and is mentioned in some different papers. But basically what this study did, developed this questionnaire of 9 questions and basically taking these questions and applying them to different people to try to see if this could be like a positive screener for, does someone have maybe a social media disorder addiction? Is this, going over into that pathologic behavior pattern? So some of the things that this questionnaire asked, and there's other versions of this out there right now. This is a really popular area of study right now, is looking for some of those same behaviors that we've talked about with other behavioral addictions. So preoccupation, are you constantly thinking about your social media side or what you're going to post or when you're going to look at it again? Tolerance, so feeling more and more dissatisfied by the amount of, maybe likes on your post. Maybe someone was happy with 20 likes, but then they thought, oh, well, I guess that's not very impressive. So they need 50 or 100 to achieve that same level of satisfaction or pleasure that they might have been really excited about at a lower amount earlier in their social media use. And ask questions about withdrawal. Do they go in withdrawal? Do you experience some of that when you stop social media use, or is it a problem for you to go without social media? Persistence, displacement, asking about problem use. Does your social media use, involve you getting into arguments, whether that's online or in person, trying to kind of tease out some of those things. Another question, deception. So are you lying about your social media use? Are you not being honest or forthcoming with maybe how you're using it, maybe the extent, maybe it's a time-based question, how much time you're actually using. So deception, escape, we talked about escape, particularly I think I did with some of the gambling stuff at last week's discussion. Do you use social media as an escape from your life, your problems, your mood? So I think that kind of goes back to the question, is it causing depression? So there's a lot of studies looking at, is the social media use causing depression? or does social media use increase because of depression? And people that are more depressed are more likely to use social media as an escape avenue to try to make themselves feel better, maybe try to, target some of those pleasure pathways, maybe increase their dopamine a little bit, maybe feeling validated by posting popular posts or doing different social media interactions. So I think that's kind of a chicken and egg question right now. Is the social media causing the depression, or is the depression causing increased social media? Or is it all wrapped together in this very intimate cycle that's kind of hard to tease out right now, if we're being honest. Let's see, John asked a question. How would this be related to doom scrolling, constantly scrolling through negative news, and then that's perpetuating negative emotions when doing so? I think that's spot on. What a lot of people are discussing right now, and what a lot of different research is looking at, this kind of cycle of depressive thoughts that might be perpetuated with the social media use. So I think this is a very big area that's growing right now in studies and research. And I think that we still need more concrete data before it's going to get the DSM-5 diagnosis. And I think we need to nail down more specific criteria looking at these problems. I think I have one more slide on this if you don't care to switch. Yeah, this is another paper. So this actually just came out March of last year. So it's a review of different theories and models applied in the social media addiction and implications for further research. So I thought this was a good source to kind of look at different studies that have been done on the topic, different models, different approaches, and kind of bring some of it all together to look at what's been done so far, but really what's still lacking. What do we need to look at in the future? And John put that link in the chat. So thank you, John. Yeah, I think it's very interesting. And I think this is also evolving right now. And I think that also social media itself with new avenues like Facebook, the Instagram, Twitter, now TikTok's a big thing. I think there's a wide variety of how people use social media. Maybe the social media use of a teenager might look very different from a 30-year-old or a 60-year-old. So I think it's a big blanket statement of social media as a whole now. So we're going to need some more research kind of teasing out more of the specifics earlier on. But I think those are a really good question. Let me see, I had a note here. There are also some studies, I didn't include them in the PowerPoint, but looking at how social media affects the brain. And it really does lighten some of those same pathways that we've been talking about today and last week with the dopamine, the pleasure, the reward seeking. So we know that people can derive pleasure in these feelings with social media. I think that's really as obvious as, getting on and, feeling those pleasures and that reward yourself, looking at, a funny post or pictures and, getting those sensations. So I think now it's kind of taking that information and really trying to make it more concrete as when is this a problem and how is this really affecting us long term? And is this, making people more likely to develop addictive behavior patterns? So I think to be determined would be what I would ultimately say with this question.
Love to hear from folks what their thoughts would be on if a client or a patient came to them and said, "Hey, I'm really struggling with addiction to social media. Like I can't put my phone down." What would be some things you would try to do with that individual?
I think if I had a patient that was really describing problems with that, I would try to really structure something to do in response. So if they feel that urge, maybe try to go and be productive in a different way, or maybe take those thoughts and maybe try journaling or picking up the phone and calling someone. Maybe it's the problem is maybe not just with social media, but maybe it is a cell phone problem is the act of picking up the phone and tapping on something, because I've heard of people just needing to check their emails on their phone. So it's like, are you addicted to checking your emails, or is it just the act of, tapping and scrolling? So I think probably teasing some of that out and seeing if we could redirect some of those behaviors into other avenues probably would be where I would start.
Yeah, so I love the idea of, in that moment, I'm about to jump onto Facebook and I know I'm just going to go down a rabbit hole. What are things that we can do to break you out of that? And thinking about, phoning someone else, doing an alternative activity, delaying if we have to, right? No, I'm not going to do that immediately right now, but I'm going to do it when I'm home from work in 15 minutes, right? Setting a time limit, as John points out in and a lot of the phones allow you to do that now, right? To set certain time limits on the apps that you're using. And Tasha makes a great point of the journaling with an eye towards writing down what goals they have as well. Other thoughts on how we would approach somebody who's struggling with social media addiction? So I just want to read out Maria's response here. I've had many patients refuse admission to behavioral health because they could not keep their phone, laptop, or tablet, even though they admitted that it would be beneficial for them, and they came to the emergency department seeking admission. What do we think about that?
I've actually had that happen. And, and then finally they're talked into leaving it. So we lock it up and then they bounce out within 2 days because they're so frustrated with not being able to do that. So they just totally ignore the treatment just to get back to their laptop.
Right, and Maria's clarifying, like, these are voluntary admissions, like they want to be there, they want help. This is not a situation where we're taking away their phone necessarily because of safety, although that can play into it sometimes. But it's really so that they can engage in what's going on the unit, right? So yeah, I think this is always an opportunity, especially when it's a behavior that's a little bit nebulous. We maybe don't have a clear diagnostic criteria. We don't have sort of evidence-based therapies that doing some motivational interviewing can certainly be helpful, right? So a lot of times the focus is on this is bad. We know it's bad for your brain. Stop doom scrolling. But can we understand better sort of what they like about it, right? What they get out of it, and go from there. And Tasha makes a great point of asking them if they think spending time on social media is more important or beneficial than their health, right? And that causes light bulb to go on. I think that you can do that once you have a really clear idea of what's on the pro and con list for them. I think it's a little bit dangerous to just sort of jump into that sort of complex reflection without sort of first understanding the positives, what they like about the behavior, because then we might force them into arguing against doing the thing that we both know and they know as well could be helpful to their health.
I think if I may jump in just for a second, I think I don't have any solutions or recommendations, but I think it comes down to the stigma of something that is illegal versus something that is not illegal, and the challenges of reducing the stigma associated with both things.
Absolutely.
Mm-hmm.
I think
I would be.
Go ahead.
I'm sorry, I didn't mean to interrupt you. I would be interested too in kind of teasing out or extrapolating, I guess, from social media addiction to even smartphone addiction. Even if you're not on, a social media app, are you addicted to looking at other things, scrolling on the news on your phone, or constantly needing to have your phone on you? I know sometimes I catch myself, like, I just want my phone with me, but I know I'm not going to use it, and I'm okay not using it, but I just like having it. But just thinking back to, most people, pre-19 90s, early 2000s lived their whole lives without cell phones, without a problem. So just thinking how society's changed with that too. So I think that's really interesting and kind of gets overlapped with the social media, since that's really phone embedded for a lot of people. And safety blanket, I think that's right on, Tasha. It's, I think we're using cell phones or apps or different things as a safety blanket.
So I think this brings up a really good point, and gets at sort of our last question that we wanted to address, which was around resources for cognitive behavioral therapy, right? Because I think we can all agree, like, it's a dysfunctional, it's a irrational thought to say, I'm not going to go and get the help that I need because I'm not going to be able to access my phone for a day or two, right? So how do we sort of begin to address that? This is a link to a PDF that's actually available in Spanish as well, that goes through a bunch of different CBT exercises. It's out of the Beck Institute. So the Becks were sort of the founders of cognitive behavioral therapy, and they do a lot of online workshops and trainings. And this is one of their key sort of worksheet packets. And it's for free. There's other resources that are not for free, and I'm happy to share those with you guys if you'd like, but this is a great place to start. And this is where our paper comes in. So we're going to do a couple of these things together. So before we jump too far into it, one of the key things in cognitive behavioral therapy is helping our clients, helping our patients understand the cognitive distortions that might be going on and might be influencing these repeated problematic behaviors. So we think about sort of all or nothing thinking, catastrophizing, disqualifying or discounting positive aspects of life, emotional reasoning, thinking with our emotions, labeling, magnifying or minimizing, a mental filter, mind reading, overgeneralization, personalization, should and must statements, or tunnel vision. So when we think about behavioral addictions and we see sort of this long list of cognitive distortions, what are some of the cognitive distortions that we think are probably most prevalent, most seen among our folks struggling with, say, gambling or compulsive buying or binge eating behaviors? And you can list them in the chat or you can shout them out. So John says labeling or all or nothing thinking. Yeah, I think labeling happens a lot within this category. All or nothing thinking. Lisa mentions catastrophizing, right? Things are going to be terrible if I'm not able to buy this or win this auction on eBay for something. Maria, 100%. So I think that's maybe one of the biggest ones, is this magnification of the wins and the minimization of losses or costs associated with gambling, compulsive buying, binge eating, those sort of things as well. And I think there is still a lot of personalization as well, because of the high prevalence of early sort of personal trauma in a lot of folks struggling with a behavioral addiction. They may see sort of responses from people around them to their behaviors, and really sort of take that to heart as there's something intrinsically wrong with them, when in reality they're trying to cope with a lot of trauma. And tunnel vision, I think, can also be at play. Yep. And John makes a great point on the magnification, the minimization. They're also going to minimize their successes and magnify the things that, like a slip, that they perceive as getting back to the catastrophizing again, they perceive as sort of the end of the world sort of situation. So with that in mind, when we are recognizing that these cognitive distortions are happening, there's a few different things that we can do. So one, and this gets at a little bit of the minimizing and maximizing and some of the delay discounting that comes along, is something called behavioral activation. We talked about this last week, but this is a stepwise approach to getting somebody from that place of the behavior is driving their life to really the patient, the client, is back in the driver's seat. And we do that through sort of scheduling of activities that we know somebody can accomplish. So they build their self-confidence, they build their sense of self-efficacy. And often the first thing that they're doing is listing activities. And they can categorize those as sort of pleasurable or routine or necessary. Everything from getting groceries to going to work to scrolling doom scrolling on Facebook. You want to try to capture all of those activities, and then you categorize them as easy, medium, or hard, and then you try to schedule them during certain times of the day. See how they do completing a small subset of those activities, hopefully those that are routine and necessary, but you might want to sprinkle in some pleasurable activities as well. And then you check back in and see how they're doing. So this is a pleasure and mastery rating scale worksheet, and this is used in tandem with the behavioral activation. So once you have all that long list of activities that you want to do, your pleasure scale and your mastery scale are going to be based off of those activities. So for yourself, I would think for a moment, if you think about sort of the things that you do on a regular or routine basis, and how pleasurable they are, basically what would be your 0, what would be your 10, and what would be sort of around your 5. We don't have to share because this might be a little bit on the personal side, but each of these should be sort of individualized to the client. So you want to write down sort of a 0, a 5, and a 10, and sort of one activity associated with that. So for example, like my 0 is doing my clinic notes. I do not enjoy those at all. My 5 is sort of taking out the trash. Like I have to do it. It's not that bad. I feel like I'm contributing to our household. A 10 is like playing sports with my friends, which I really enjoy doing. So everyone has their own scale. But then there's the mastery scale as well, right? So you want to be balancing as you're scheduling these activities, activities that are pleasurable, but also activities that the client feels like they are confident that they can accomplish, right? So we're not going to schedule a whole bunch of 0s on the mastery scale. We're going to try to aim for those, in that 5 or above. So example there might be like a 0 on the mastery scale for me. Geez, I don't know. I think a 10 is probably easier for me. A 10 is like seeing my chronic stable patients in clinic and just sort of checking in. A 5 is like seeing a new client that I don't know anything about. And a 0 would be, seeing a new patient that I don't know anything about, who has an issue that I can't treat or manage. so that's sort of what we're getting at with the mastery scale. But for you, it might be, public speaking is on the 0, right? And 10 is sort of watching our favorite television show, right? Like I've got that on the remote. I know my spot in the room. So that's the key here is working with the client to come up with what are the activities that fall under these categories, and can we make sure that when we're scheduling activities, we're balancing pleasure and mastery in a way that allows them to achieve as much of those activities as possible. So let's say there's an activity where they really want to accomplish this, but maybe they have lower mastery, or they just have a hard time sort of seeing how they're going to get to that goal, that objective. That's where a graded task assignment worksheet can be helpful. You're going to start with very small and simple tasks that you want them to complete, and you're working towards sort of that final task that will allow them to meet their goal. So for example, we have 1, 2, 3, 4, 5, 6, 7 steps here. So I want you to think through, let's say a client comes to you and they say, I'd like to buy a car for myself, right? That's my biggest goal. I need a car. So that's sort of, you're going to write buy a car on the last step there. And then you're going to go back and you're going to ask, okay, what's our first step towards buying a car? And work through them with that. So for now, what I would do is try to, on your own sheet of paper, so write buy a car on this top step. I don't know if you can see that. So you have your steps, you write buy a car at the top. And I want you to think through maybe 5 or 6 intermediate steps that somebody would have to go through to get to that point. Because if you are able to think through those, you're going to be able to help guide the client to that point as well. So Barry's already thrown some tasks in here already. So good. So what were some of the initial sort of first step or second steps that folks had? So price range. Yeah. So trying to decide on a reasonable price to pay. Good. John, I'm gonna do some annotation. So we're gonna talk price point. Okay. And then what comes after that? So Tasha mentioned sort of budget to meet that price goal, right? So a lot of focus on the financial part, which I really love. I think that's a key part of it. And then research cars in that price point. Then once we've researched, what are we going to do next? So yeah, I think safety, options, like part of this is getting back to the price point and like what are my needs initially, right? I think if you mentioned sort of a test drive, certainly reasonable. Yeah, and we might need some negotiation skills here. So this is not a perfect stepwise graded task assignment, but what you just want to get something out there, because then you can allow for some discussion. You can ask questions like, well, where does insurance fit in here, right? Or where does credit fit in here? Are you buying it cash, or are you going to be taking out some loans to do it? Who am I buying from? So all those things allow you to dive a little bit deeper with the client, and hopefully identify some steps that maybe they didn't think of, but actually they might have great mastery of because they've done it before, or they know that that's an important thing to do. And if we can schedule those things that are going to improve their sense of mastery and improve their self-confidence, then when we set a goal of, stop gambling and begin working through the tasks needed to get to that point, we can begin to see a little bit more how we can get there. We talked about this sort of two-sided reasons for and against changing unhealthy eating habits as it pertains to binge eating last week. I think this is a great one to use with clients before doing those more in-depth or probing questions about really what's getting in the way of them making a change. And we talked about the behavioral change worksheet. So think of this as sort of the mirror image, so slightly different, of the graded task assignment. Because what this is doing is that something bad already happened, right? The consequence already occurred. And now we're going back to try to understand our thinking from a cue or something that triggered eventually that consequence, that maybe that binge eating episode or returning to gambling. We're trying to understand what all connections got us to and thoughts got us to that point as well. So any questions about some of the CBT exercises here, or general questions that I can answer as we're wrapping up here? Yeah, Lisa, so all of these are in the Beck CBT worksheet PDF, which is a huge document. There are a lot of great exercises in there, and it includes the graded task assignment, the identifying behavioral chains. So all that is in there. What I would encourage folks to do is pick maybe one or two of these. I really like the sort of graded task assignment because it's very simple, it's very straightforward, and just practice it with clients and see what information you get out of it, what follow-up questions you find yourself asking again and again, and where people get stuck, right? I think a lot of times it is in identifying what's that initial step, and you can always help them out a little bit, but you want to hear out first sort of what they're thinking and where they're at.